Okay, so how many people we got going here?
Quite a few registered. Yeah,
Attendees.
there you go.
All right.
Make sure, yeah, everybody. Okay,
Perfect. Okay.
That's great.
All right, so welcome everybody. We're gonna go ahead and get started. I'm actually in Tampa with Dr. Harrison and his team. So this is where the webinars usually start from. So I get to see the epicenter. So I had a couple of cases that were really, you know, they provided a lot of questions for me, so I thought I'd share those with you. So let's see, how do I get this thing to go? Okay, so the first one is, so the basic theme today is what is the best recommendation as a pre-op or pre-stem cell therapy advice. So the first case is a 64-year-old with myeloma and amyloidosis that has confirmed cardiac involvement, who is being treated right now on maintenance with Velcade and Revlimid. He had gotten more intensive therapy 4 to 6 months ago, but his disease responded, so he's on lower doses less frequently at this moment. And currently he's, according to his oncologist, has achieved remission. What happened there? Just kicked out.
The deactivation after so many seconds.
There we go. Okay, so he's being considered for an autologous stem cell transplant, and you know that's basically the question that we were asked was, you know, is this a good idea? So his past history, he's got hypertension, hyperlipidemia, chronic kidney disease. He's had a couple episodes of heart failure in the past, including in February of this year, he was admitted for low-grade fevers and heart failure type symptoms. So he's had actually some symptomatic heart failure in the past year. He also has coronary artery disease. He had an AV nodal reentry tachycardia and had an AV nodal ablation, partial ablation back in 2013. And then he's had a DVT before. He also had polio as a child, and then he has sleep apnea. So his current medicines, I didn't list all of them, but I just put the cardiac ones. He's on some other supportive medicines. But he's on Coreg, aspirin, pravastatin, allopurinol, and Lasix. And there's his EKG. I don't know if anybody wants to take this one on. Maybe Greg. You there, Greg? Is he audio? Nope. So, Eric, I don't know. What do you think about that EKG?
Sure. Excuse me. So I see a normal sinus rhythm with funny-looking P waves, and so it may be a different atrial or a nodal focus of some sort. And then it's a slow rate. It's definitely bradycardia. There's one premature beat that I'm not sure if it's atrial or ventricular. The voltage doesn't seem particularly low by most standards, maybe in the limb leads, but certainly no low voltage in the precordial leads. And then there's Q waves across the precordium in V1, V2, and V3, 4. And then it's finally get an R wave in V5 and V6 with a prominent S wave. And so, you know, and then there's really Q waves in the inferior leads as well. So perhaps that represents some old cardiac events, or perhaps it represents some electrically silent areas from amyloid deposits. And he's got some prominent voltage and maybe some right ventricular conduction delay. I don't have the QRS duration there.
I think it's okay.
Okay. All right. Good. So that's what we got.
So, at least based on this EKG, would you say that that is consistent with amyloid or consistent with coronary disease or both? Or you're not sure?
Yeah, I would say that anything that gives you prominent Q waves everywhere, would be consistent with having deposits of some kind of material in the heart, which would go along with amyloid, sarcoid, whatever. And of course, you can't rule out having had, knowing that he has coronary artery disease, you can't rule out he's had prior cardiac events involving the inferior wall or the septum. So could go either way.
All right. So, come on now, be nice. Okay, so here's an echo that was done about a month ago. Can everybody see the loops? Yes. Anybody on there can comment on the movement?
So this is correct. Dr. Morales here.
Okay.
Wants to comment on this? Sure.
What happened? The loops
so the loops kind of stopped, but at least
there we go.
Yeah, at least radio track was okay. Systolic function looks okay, but systolic function is looking north to me. Basic expression is very minimal. You see a significant thing for possibly electrical hypertension. And of course, small size with some you can help on the personal fractures tissue.
So, yeah, so overall, yeah, like some significant evidence for these things. Okay. So then, so that was the echo, which shows, normal LV function with some significant hypertrophy. There, I didn't show any of the loops of the valvular disease, but there was no significant valvular disease. And so then his physical exam and basic labs are presented on this slide. So his blood pressure is okay, a little higher than most of my heart failure patients, but so 130 over 78, pulse was 70. He did have some JVD, a very loud S4, and then some edema. His basic laboratories include a BUN and creatinine of 58 and 2. A troponin was 0.09, and a BNP was mildly elevated at 221. So when you think about a pre-op risk stratification for a stem cell transplant, you have a hard time finding out what exactly is an accepted test. So I don't know if anybody has any thoughts on that. You guys, you ever had to address a pre-stem cell therapy, pre-op evaluation essentially?
No.
So,
but I would be concerned about the BNP being 221. That's, he has a history of sort of chronic congestive heart failure, so it's not acute on chronic, but he has a history. He has certainly not too bad systolic function, but I'm concerned about that. And then we've been doing a lot of work on looking at the cardiac coronary plaques with cardiac CT. And the fact there are 40 and 60% lesions and 30 and 40% lesions, that represents increased risk of having a cardiac event, because it's 75% of heart attacks come from plaques that are 30 to 70%, less not severe obstruction. So, so those little plaques some of them could be very high lipid laden with thin fibrous caps, and so those are a concern too.
But I mean, the real difficult problem there is that, so whether you have mild disease or moderate disease or whatever, you know, what is a yes/no type answer, a go or no-go answer for a pre-stem cell transplant?
So, Dan, this is Ann Blaze, and we recently published some or presented some data at the Tandem BMT meetings in February, and we're in the process of publishing them. But looking at patients with heart failure and can they go through transplant, and at least in this was a retrospective cohort that we did. Those patients certainly they did fine. It didn't affect their outcomes at all. That doesn't. The reality is there's not good literature in this area, which is why we have tried to publish this and are in the process of doing that. But it was a hot topic at the Tandem BMT meetings in February and was presented orally there. If you just look at ejection fraction, people can get safely. It doesn't affect their mortality associated with the transplant.
Yeah, I mean, especially in the case of amyloid, I mean, your EF is pretty much a meaningless number. So I think that, you know, you can't use that as a deciding point, because that really is not telling you anything. So, well, I mean, I'm really glad you spoke up, because I really don't believe that there is any data out there as to how to risk stratify people, and then, you know, whether you do some test, whatever that test is, and if they, quote, fail that test, then they shouldn't get a transplant because they're not going to survive it. You know, there's no guidance out there that I'm aware of. So I think your data would add to a vacuum for sure.
Right, yeah.
So that's great. I'm really glad. So we encourage you to publish that.
Yeah, it's in the process of getting submitted. Thanks.
Yeah, no, I know about things on desks. I got plenty of them. But anyway, no, that's really interesting. So as we started an amyloid program about two and a half years ago, and you know, so there's a lot more amyloid than I thought is my first comment. But the second is, we have come to this place so many times that we didn't really have any data as to what would be an appropriate preoperative or pre-stem cell evaluation, and then what result would tell us whether this person should proceed or not. So with that in mind, we developed a consensus opinion that, you know, of course you're going to get an echo just because we do a lot of echoes, but as I said, I don't think EF is going to help you out. And so we felt like we needed some sort of functional test. And the best global functional test in people that have heart failure is probably, you know, an MVO2. So our strategy was to, in any patient that has amyloid or myeloma that is about to undergo a stem cell transplant, we would do an MVO2 and see what their cardiorespiratory function is, and you know, use that as a deciding factor for go or no go. So that's what we did.
Somebody has their hand up for a question.
Yeah. Somebody has a question here. Let's see. Dr. Zaza? Does he have a question?
Probably can't.
I mean,
did he type something?
I don't see it.
You can see if he's muted.
No, Daniel, it's okay. I mean, I'm listening to you. It's Zaza.
Okay, great. Thank you so much. Are you listening to this from Tel Aviv?
Yes.
Awesome. We're so glad.
I'm glad to be with you. It's a great discussion. Thank you.
So anyway, so we did an MVO2. This guy had polio, so he couldn't walk quite normally, so we did it on a bike. And it was 12.7, which is, you know, not so great for the people that exist in the possible transplant world, cardiac solid organ transplant world, an MVO2 of 12.7 is pretty reduced, and that would get you on the transplant list. So that's not all that great. But that was done in February, and then he had a cath about 9 months ago, and you see the results there. And then he had a right heart cath about 4 months ago, in which we did the cardiac biopsy to confirm amyloid. And his PA pressures were 44/20 with a wedge of 22 and a thick index of 2.71, which for those of you who are not used to seeing that number is not normal, but it's not too bad. So if your thick cardiac output index is less than 2, then that's pretty severe. If it's greater than 3, and you're probably in the normal range. So he's mildly reduced, but not too bad. So then, my slide, is it going to move forward here? There we go. So part of this we've discussed. So what are the effective pre-op evaluations? Is there any other tests that you think would be needed to give sort of a go or no-go answer to the oncologist on this one?
You've done an MRI, haven't you, as part of the workup?
That's correct.
Kidneys too high.
Yeah, I was going to say, I can comment, at least at our institution, they would do an MRI as far as adding additional information. I think it's really difficult to know, to deny somebody. In this case, it's an auto that's going to improve their outcomes. When you're looking at like leukemia and an allo is their only potential option for getting rid of this disease, it's very difficult clinically to deny them the option.
Yeah, I don't know if we would so much say that we were going to deny the option, but, I can say that when I was at MD Anderson, if a person had heart failure at any point in time, that they would not do a transplant, period. Mm-hmm. They wouldn't even talk about it. So at least at Vanderbilt, we've gotten them to engage in that conversation. So in this patient, he would have not been considered previously, but because he had previous symptomatic heart failure. Right. I think that that is probably doing a disservice for the patient in the sense that, as you point out, that the transplant could be a very important therapy for him.
It could be the only therapy for him.
Yeah, I mean, he's already on the common medications.
Yeah.
And that seems to be holding it at bay, but it's not gonna be curative.
Right.
So then, from a cardiac point of view, I don't know if the cardiology people have any comment. So what would you say? So if you say it's got mild to moderate coronary disease, a little bit of evidence of heart failure, MVO2 is not so hot, but he is getting chemo. So how do you put all that together? What do you tell the oncologist? Good luck. Yeah, you tell him good luck, or what do you tell him? So I don't know. I think that the conversation that we've had has been, in a way, I've had to convince them to do the transplant because they wouldn't, because of the history of heart failure, they were very reluctant to do it. But I really think that seems like the best available oncology treatment for him, and hopefully we can get him through the transplant. So,
what was the mortality? I mean, what did the oncologist say his prognosis was, being that he has cardiac amyloid and he had heart failure? With that type of amyloid, usually they're not around very much after a year, or they have at least a high mortality within the first year. So how much more bang for your buck would you get with a stem cell transplant, and would that improve probably not his cardiac amyloid, and would you be looking for a cardiac transplant at some point in the future?
Yeah, so Ann, I don't know if you have any comment about that. Do you think that an autologous transplant provides some bang for his buck, so to speak?
Yeah, I think it provides some, in terms of outcomes, there's a potential for him to have a really good durable remission from it. Do I think he's ever going to be a cardiac transplant candidate? No. Not in today's world. I mean, maybe down the road, but I don't think so today. I think you have a disease that even with the transplant, you're looking at him obtaining a very good remission, but not a cure.
No, and I think that in the transplant, cardiac solid organ transplant world, the general expectation is that you have a complete remission for 5 years.
Exactly.
For any sort of major malignancy.
I haven't come across any data that suggests that fixing or curing the amyloid with stem cell would reverse any of the cardiac amyloid problem. Have you found any of that in through your research? Is there any reversibility of the cardiac amyloid with treatment?
I haven't found that, no.
Yeah, well, so this is one of those things on my desk, and so I'm encouraging you to get it off your desk. But so one of the things that is on the pile of stuff on my desk is we actually had a couple of patients that had amyloid, went for their stem cell transplant. We biopsied them before the transplant, to confirm the presence of amyloid. And then 2 patients, for one reason or another, about a year after their transplant, came back. They were still having some heart failure symptoms. So we convinced them to allow us to do another biopsy. And actually, by EM, you could see some really significant changes in terms of pre-transplant. There was, all the typical findings for amyloid, including a lot of disarray in the structure, and then afterwards, it really looked more organized. So I felt like that was pretty convincing evidence that if the heart has a chance to process the protein overproduction, that it can't. There is some reparative function, but it's going to be hard to prove that. So. And then there's a couple of medicines out there now that are intended to prevent the deposition of the protein in amyloid. So, one of the considerations is how do you prove, an improvement? How do you establish an improvement in cardiac deposition? And so that's a really difficult question.
Were there any recommendations as far as medications that you provided to the oncologist? I know that ACE inhibitors in patients with cardiac amyloid can in some cases be not a very good thing. For some reason, unclear reason, they don't tolerate it well. They become hypotensive. They don't tolerate beta blockers as good, so you kind of limit it with that. And then going for a stem cell transplant with coronary artery disease, you don't want to recommend aspirin. I guess you're kind of limited to just a statin at this point. Was there?
Yeah, and I think that most oncologists would probably hesitate about giving a statin in the context of a transplant, because there's so many other drugs going on, that
liver
patients are already so sick. So, yeah, I mean, I think that this person has known coronary disease of a moderate variety, and then he's going to get, an ablative level of chemotherapy. His platelet count's going to go to the tank for probably at least 2 months, maybe longer than that. And, they're going to want to stop the aspirin, but we really don't want them to stop the aspirin, and we definitely don't want them to stop the statin. And amyloid patients are notorious for not tolerating typical vasodilators, so Coreg or ACE inhibitors, frequently you can't get them on anything because they're hypotensive. So he actually has a little bit of blood pressure to work with.
Nice.
But so anyway, I pulled this off of marrow.org. So this is the outcomes of people that have transplants for myeloma, and you see that they don't actually have any data on amyloid. So I don't think it's, they don't have as much experience, and so they don't have any specific data about amyloid. But this person did have myeloma, so he fits in this category. But you can see that the autologous transplant is generally much better tolerated than some other kind, either allogeneic or matched unrelated donor transplant. So those are not really good treatments for a myeloma patient, mainly because they're very intense or very risky. So Anne, I don't know if you have any comment about that.
No, I would just agree with those. And like for myeloma, we only do autologous transplants. The sibling and unrelated donor transplants are done typically for leukemias. And in those situations, you really don't have other options. There's a couple newer medications that can hold things at bay for a short period of time, but otherwise you're really looking at succumbing to leukemia in a short period of time. And so that's part of where, when you get them in remission, it's kind of like go or no go from a clinical decision-making standpoint.
Yeah, so in this particular patient, he has not got his transplant yet. We're still in the negotiation phase, and the current negotiation is that he's going to repeat the MVO2 test. In February when he did it, and it was 12.7, he had some evidence of heart failure, and between February and now I told him no way was I going to agree to letting him go for a transplant unless he did cardiac rehab, and he took his Lasix every day and lost about 15 pounds. And he's actually done that. So he completed cardiac rehab for 12 weeks. He lost about 15 pounds, and his activity level is much better. So I'm hoping that his MVO2 will improve. But I think that if we had transplanted him back in February, probably would have killed him. And I'm hoping that his increased exercise has put him in a different spot. So that's at least my current argument. So hopefully they'll proceed. I think they're ready. So then we have another case. This one is quite challenging too. So 66-year-old, previous coronary disease, had aortic valve replacement with a bioprosthetic valve in 2006, and then was diagnosed with non-Hodgkin's lymphoma in 2012. He was treated with anthracycline-based therapy for 4 cycles, and he did okay. And then at the end of his 4th cycle, they did an echo for some reason. I think it was because he developed some symptoms, and his EF was 35%. So they felt that he was in remission at 4 cycles, and they stopped the therapy. His past history is for typical cardiac stuff, coronary disease with bypass and AVR, hypertension, hyperlipidemia. He's on the usual fanfare of therapy for the most part. So in 2012, 3 months after he finished his anthracycline, he developed chest pain and was admitted to an outside facility and got a drug-eluting stent to the right coronary artery. So this is in August of 2012. He then came for follow-up in December of 2012 and was reportedly asymptomatic, although not a very active person. So then come around to February, March of 2013, he had recurrent lymphoma, received 2 cycles of non-anthracycline-based treatment, and then he was being considered for a stem cell transplant. So his physical exam and labs are shown here. Blood pressure is fine. Really had no evidence of JVD, but he did have a few crackles in the bases of his lungs. Had a loud S4. His PMI was enlarged. His labs were pretty unremarkable. His BNP was 107 and a troponin was normal at 0.01. And then this is his EKG. So is Greg audible these days or not?
That's right.
Greg, are you there? I'm trying to pick on you. All right, we got nothing from Greg. All right, so
It's like sinus rhythm with a complete right bundle branch block with associated repolarization abnormalities. And axis looks pretty good. Yeah, I mean, pretty much.
no mic. Okay.
There's some subtle inferior. Looks like there could be some ST elevation there. Not quite clear, just in lead 3, but
It's a Q wave.
yeah, Q wave, and lead 3. I've always been told to ignore unless you see it in leads 2 and AVF. But yeah, you got 1 Q wave in lead 3, which could change with just deep breathing, reposition the leads. So other than that, that's pretty much it.
Yeah, it was only the previous drug-eluting stent.
That's right.
So
Yeah.
So then, his pre-stem cell evaluation, which I'm not sure I know exactly what that is, but in his case, this is what was done. So in May of 2013, he had an echo that showed his EF had recovered some to the 45-50 range. He did have a slightly elevated aortic valve velocity of 3.1 meters per second, which for the non-cardiologists in the crowd would probably be in the range of moderate aortic stenosis. And then his BNPs are listed there from December of 2012 to June of 2013. And so he's had sort of moderately elevated BNPs at times, but he's also had periods where his hemodynamic status appeared to be pretty optimized. And then his echoes are listed there. Many of those were done outside facility, but so he started off before his chemo with a normal EF, and then you see in April of 2012, that was after 4 cycles of anthracycline, that was his EF of 35, and then it got a little worse in July that year, and then in August of that year, that was when he presented with the acute infarct and got a drug-eluting stent. So now what do we do? So we're back in June of 2013. He had his drug-eluting stent in August of 2012, and he has recurrent lymphoma. He's already been through a couple of lines of therapy, and so they really feel quite strongly that if he's going to get treated for his lymphoma that has any success, it probably should be a transplant. So what do we tell him? So is there any further preoperative evaluation we should do?
You got a stent in August, and we're
in June.
In June, so he's still not. Still got another month or so. Well, he should probably ideally stay on the Plavix, depending on which kind of drug-eluting stent. And he's not having any symptoms at this point?
No apparent symptoms. He has some dyspnea on exertion, walking about 3 blocks, but that is a little bit better than it was a couple of months ago. No chest pain.
No chest pain.
Can we see its echo? Do you have that for us?
So I do have echoes, but actually, so I have an MRI. So I did an MRI.
So yeah, it's got hyperperfusion in the inferior septum there.
So for the non-cardiac MRI people, this is an adenosine MRI stress test, basically. And you see how that is done. Essentially, is that they give the dye right at the time of getting adenosine, and so you should have vasodilatation. And when dye goes in, you see that most of it starts out dark. The left ventricle starts out dark and lightens up when the dye goes into the viable tissue. And then you see in the inferior septum there's a small area of where it stays dark and it doesn't ever blush, and that's evidence of a prior or or a prior infarct. So then, so on the left, basically the systolic function, and on the right is the gadolinium still frame. And I have a narrow septum where you see an increased gadolinium uptake, fibrosis or prior infarction in that area. And then the EF measurement by MRI was measured at 38%. It doesn't really look all that great to me. But
on these slides, the audio is degraded in quality and overloaded. So if you want to click next and then discuss it,
okay.
That's.
So I understand our audio issues are a little bit of a problem when we're showing the loops, so I skipped over the loops there. But basically what the MRI showed was that the EF was 38%, although visually it didn't really look all that great. And then he has evidence of a prior infarction in the inferior septum, no evidence of ischemia. So is there anything else we need to know, or what do we need to tell him? So this is a guy, moderate LV dysfunction, some heart failure symptoms, probably class 2, EF in the high 30s, who is kind of at the last step as far as his lymphoma is concerned. So if he either gets some not very effective chemo or he gets a stem cell therapy. So what do we tell him?
When they did the cath, the other coronaries, the grafts themselves, they were fine.
Yeah.
Pretty much.
Yeah. Mine, mild or moderate disease, nothing that required any kind of intervention. So does anybody have any comments out there? Susan, what do you think about this? Are you still there?
I think it's still another area that no one's really looked into very deep. So
sorry, I'm here.
So what do you think about this? I know this isn't necessarily the disease state that you deal with the most, but what is your sense about a relapsed lymphoma patient that has cardiac dysfunction and coronary disease?
I think my feeling is that this is their only option, and that and at least when I used to treat it in our center, that would be the standard option for relapse disease. So I think if we can optimize the cardiac status, I think I would tend to go for it, because really I think the outlook for without the transplant for the non-Hodgkin's lymphoma is not good. I think with it, they have a chance. So that's my feeling. I would not really treating this as much anymore, but their outlook without the transplant is not good.
So is there any comorbid disease that would say you're not even going to offer transplant?
I think if they had, so are you asking how severe does the heart disease have to be?
Well, yeah, or you know, even if we
yeah.
don't talk about heart disease, if we just say pick any disease you want to pick.
Sure.
What
so
other?
The other thing is, obviously, the other thing that in my mind would be, let's say they had, you know, severe COPD to the extent that, you know, their performance status was so poor. They had very poor respiratory reserve, because obviously that would affect their ability to survive the transplant as well, right? So I guess if you look at the constellation of symptoms, if this individual has severe heart disease, if they have underlying severe COPD, all of those are going to increase their risk of surviving the transplant. If they had, you know, another, and I've been seeing this more frequently, if they had another secondary malignancy, which he doesn't have, but lately I've been seeing people with concurrent malignancies, if that were the case. So I think one of the strongest predictors for me is, do those comorbidities increase his risk of not surviving the transplant? What is his performance status going into the transplant? Because that is a very strong predictor of outcome. And if that's poor, despite, you know, your best optimization with your cardiac drugs, then you have to say it's likely he may not survive it. So I think that's the balance, is determining, can you optimize all the other comorbidities enough for him to even get through the transplant, regardless of what, you know, what's the best treatment for his non-Hodgkin's lymphoma.
And I would also just add to that, this is Ann, but I would also add to that for a lymphoma, he'll be getting an auto transplant. It would be my assumption, not an allo. Mm-hmm. And the intensity of the transplants are quite different when you're looking at an allo compared to an autologous transplant. And the autologous has a potential for cure. He doesn't have good options outside of that. And I don't think the EF by itself is it makes the risk higher, but I don't think it's a contraindication. I think, like Susan said, I think of other kinds of cancers. If a patient's on dialysis, you have to kind of really think twice as far as doing a transplant. But you also have to ask, like, which kind of transplant is he getting? In this case, it's an auto, so the intensity is still a lot, but is less than an allo. And the second thing I would also just, he's gone through a stress test on his own by getting through 2 cycles of rice chemotherapy. Those are fairly intense on their own, and so you could also argue he has gone through somewhat of a stress test already in order to get there.
Yeah, and I think so. Again, we get into a little bit of a sticky point, you know, in terms of his cardiac status. You know, to put it in cancer lingo, he's probably an ECOG 1, so he can walk several blocks without stopping, but you know, he does have some cardiac symptoms. So I mean, he's not completely asymptomatic. And then he doesn't have anything really terrible. He has a lot of not so good things, but nothing really terrible. So his BF is moderately depressed. His coronary disease is probably stable at this moment. His aortic valve disease is kind of moderate. So everything is just sort of moderate. And in series, I don't know if all of those things add up to something more severe or not, but given that this is probably his only viable cancer treatment option, I think, you know, we again argued the point, you know, take your best shot. But then you still come back to the place, what do you say about aspirin and Plavix? So
wait the 12 months first. Well,
you can't, it's not that easy, because if you you know, the oncologists have already done their preparatory chemo, and they think that, you know, if he's going to get a stem cell, it needs to be sometime soon. So you can't wait for 3 or 4 months. You know, they want to do it now if they're going to do it.
I don't think there's anything magic about 12 months in this particular case either.
No, I mean, the cardiologist pulled that out of their ass.
Yeah, I've heard that.
They just said, we're going to pick 12 months because it's easy. We can compute that. But, you know, we haven't
Hello?
really. Yes.
Daniel, I have
Yes.
a question. It's Zaza. About his assessment of cardiac status, about the aortic valve. It seems to me, in the presence of moderate LV dysfunction with moderate aortic stenosis, maybe we're dealing with low cardiac output, low gradient aortic stenosis. Maybe it's even not so difficult thing, and maybe optimization by clinical therapy would be better for this patient. I mean to assess his valve by the vitamin echo.
Yeah, I mean, that's an interesting point. And
Just depends what the aortic valve area was at the time. Was it still, if it was severe, then yes. I think if it doesn't take into account that. So.
well, if you go back all his echoes, that most of them were done at an outside facility. So I had a range of reports on the echo for his aortic stenosis from not existent to mild to moderate to severe. So in the 6 echoes that were done at outside facility, there were
So we need one definite echo,
yes? Yeah. So the problem is that I agree. That's an important point, and I think that whether his valve disease is more significant or not is certainly a relevant question. Again, I kind of came in this particular situation. I kind of came back to, you know, I'm not sure I really want to know because I didn't want to do anything about it, and it's not like we would even consider, you know, a TAVR or something in preparation for a stem cell treatment because, you know, really you're introducing the whole antithrombotic mess right before a time that a person's going to have no platelet count for 2 months. So I don't think that the end result.
Even you can do valvuloplasty, you know, to go through it, and afterwards you can even do TAVR if it will go, everything will go okay.
Yeah, I mean, I think it's a valid question. I acknowledge that. I kind of voted in this situation to leave Pandora's box alone, but that was just my vote.
You had the data from the MRI and the aortic valve?
In the MRI, the aortic valve was really in the mild to moderate range.
That's pretty good data.
So.
Okay.
So anyway, we said in this particular patient that this is just, again, some data from the marrow.org, just showing you kind of the outcomes after transplant. So what do we say for this patient? Well, as best we could tell, he was stable, and then I thought it was probably pretty risky. So if you had to put on a sheet some sort of statement, what's this cardiac risk, I just don't see how you could say is anything other than high risk. But, you know, it's not like he's a low risk. But on the other hand, from a cancer point of view, that was his best and really only treatment option. So, and then what do you tell him about aspirin and Plavix? Again, I go back to that because it's a problem. He's got a bioprosthetic aortic valve, and he's got a recent drug-eluting stent. So he has very strong indications for aspirin and Plavix. So I think
you can stop it.
He'll be okay.
Yeah, it'd be autoplavix.
That's right. Yeah, so I think that pretty much the final analysis of this one was we just told them to have a party. You know, we discussed all of this with the patient and said, you know, we don't know exactly how to stabilize your condition any more than it is, and you know, from a cancer point of view, that's your best treatment, so we'll take our shot. So, Ann, I don't know if you have any additional thoughts about that one.
So, sorry, it's Susan. So, I mean, I think I would agree with that. I think those are the risk-benefit discussions that, you know, that we have with patients. And if, you know, if you say no because it's too risky, but then you die of your cancer, I mean, you know, that's the risk-benefit ratio. So it really is a personal choice for that individual based on them knowing what the risks are of both going forward or not going forward. So I think that's the best we can do. And some people will decide to take that risk, even though it's high risk, and others may not, depending on you know, their personal feelings. So I think that was a good case, and I think that's, you know, they're tough decisions, but they're ones that we face every day.
Oh yeah, no doubt. And I think, but to me, it was the thing that I would emphasize is, you know, kind of what Susan and Ann said is, you know, having a conversation with the oncologist and asking them these types of questions so that you understand how important that treatment is for that patient. It's really necessary to put that into the equation. I think that if you just look at stuff and you don't think about the other side of the piece, that you know, you would say, you know, you shouldn't be doing anything like that to this patient. But on the other hand, you know, understanding how important that treatment is sort of critical to the decision making. So, all righty.
Very good.
Very good.
Thank you, sir. Enjoy it. We'll all get together for the steering.
Thank you.
Okay.
Thanks so much.
Thank
It was
you.
excellent.
Yeah. So as a reminder, we.
Congratulations,
Thank you. In 2 weeks, we will have our steering committee fellowship discussion via this webinar, and then the second week in July, we'll have another case. I don't know. No. Somebody will be doing the case in July, and we'll send out an invite. Thank you all for joining. We really appreciate it, and look to hear any feedback, or if anybody wants to contribute a case, we'd love to hear about it. All righty.
Okay, thank you.
We'll post this
Have a
on the
good
website too. All right. Thanks.
Bye. Thank you.
We'll post this today?
Yeah.
What's it? So now it's
Nice.
Good
Saved.
stuff.